Deborah Goldman to the Body Pod. We are so thrilled to have you here. This is a very different subject, and we haven't had an expert on in this pelvic floor area. So welcome.
Thank you. I'm so excited to be here. It's
We're so excited to
truly an
have you.
honor.
Can you just give us a little intro about yourself and how you got into pelvic floor physical therapy? Because I don't even know that every woman knows what that entails. They might have heard the name, but couldn't tell you exactly, what actually happens.
Okay. Well, I'll start off by saying I'm a late bloomer. So I didn't go to physical therapy school until I was 33
Oh, wow.
after a career as a modern dancer and movement teacher. I taught exercise at NYU's fitness center. I did body work. I became certified in something called the Alexander technique, which is all about posture and breathing. And then, and I was, as I said, I was dancing. And then I realized I needed a career, and I was attracted to physical therapy because I had always been very active and physical. And I went to school after completing my prerequisites, even though I had two other degrees, because I managed to avoid science and math for so long that,
Been there, done that.
yeah. And so graduated from Northwestern University, a fantastic school. With a degree in physical therapy, and immediately moved back to New York and went into sports medicine and orthopedics for 12 years. So I worked at a wonderful training and physical therapy facility in the World Financial Center, and had a really great experience treating every type of sports medicine and orthopedic surgeries, uh, knee surgeries, elbows, backs, um, lots of great collaboration too with fantastic orthopedists in New York who loved sending their patients to physical therapy and really believed in what we did. But I started to have an interest in women's health too. And then when I was there for a few years, then um, I was pregnant and at 40, and with my one and only, and I discovered um, a book called the essential exercises for the childbearing year, which was written by an Australian physical therapist. I know you love Australian people, and so do I.
Yes.
And Elizabeth Noble was someone who had come and moved to the United States, I think in the late 60s, but wrote this book in 1976. Like there was nothing else like that. So, and she actually started in my professional organization, the American Physical Therapy Association, the kind of the groundwork for what we know as pelvic floor physical therapy specialization. So when I was pregnant and postpartum, I used her book as my guide to my postpartum recovery, and it was really more exercise based at that time, but there was nothing else like that. So fast forward a couple years, and I started a practice in New York at a midwifery run childbearing center, which was the one of the few of its kind. And I worked closely with the midwives and the assistants there. And I started seeing a lot of pregnant and postpartum patients. And I knew I was missing something, but the pelvic floor aspect wasn't really in my consciousness at that time. That was like 1999. And um, but in any case, and a few years later, in 2002, my family moved to New Jersey, and I was trying to figure out what I was going to do because I didn't want to work for a big practice anymore. And so I was trying to figure things out, and I put myself out there on my professional organization as someone who's interested in women's health. And I was contacted by a young physician who was just starting his urogynecological practice at a local hospital. So urogynecology at that time was a relatively new field too. So urogynecology is kind of the marriage of obstetrics, gynecology, and urology with emphasis, solely on women's pelvic health. So I
Wow.
met,
Wow.
yeah, so I met with him, Dr. Siegel, and he convinced me that I should study pelvic floor therapy because he was looking for someone to refer his patients to. And it just was kind of serendipitous because I really was looking for something else. And um, I just kind of dove into the coursework and immediately loved it and found it, incredibly interesting, and realized this was my niche because this was everything that I kind of wanted to put together, that still having the orthopedic sports medicine mind, but really focusing on women's health.
Mhm.
So I quickly started my own private practice. Plus, I worked with him at the hospital 1 day a week, 1 day a week for 8 years. So I learned a lot about urogyne, about prolapse, about urodynamics. I had residents and medical students shadowing me. I was able to give grand rounds at the hospital to the attendings and the residents in this on pelvic floor function. So I had a great education on that. And then so as I said, I did that for 8 years, and then I kind of focused more on pelvic pain. So I really see a wide variety of patients, um, male, female, I accept all genders, all sexes. Everyone has a pelvic floor. I don't see children, but that's kind of how the trajectory of my career started back in 2004 after my 12 years as an orthopedic sports medicine physical
Okay.
therapist.
So let's break down what pelvic floor therapist, if somebody's coming to you, because I think I shared this with you earlier on another podcast or just
Hmm.
when we were chatting. I was seeing a physical therapist for a hamstring issue that was not getting resolved, and I don't know why, but somehow she was like, "Did you have trauma with any birth?" And I said, "Yeah, my last child, blah blah blah, XYZ." And she said, I think you need to see a pelvic floor therapist." I had no idea that it was like what it was, and what it entailed, meaning I didn't know it was an internal exam. I thought I was just like going for physical therapy and I didn't know what they were going to do. So I know I can't be the only one here. What if somebody were to come to you? Well, first of all, if somebody were to ask you what you do, can you break down what a pelvic floor
Hmm.
physical therapist does, and then how a session would go
Yeah.
with you?
So typically, the things that people come to see a pelvic floor physical therapist are bladder symptoms. So it could be, urinary leakage, retention, frequency, um, stress incontinence, urge incontinence, and we can go into that a little bit more later. Different types of bowel symptoms, constipation, hemorrhoids, fecal incontinence, and perineal trauma, which can cause all of those above, and that's from childbirth injuries. Sexual dysfunction, that includes pain with penetration, um, the medical term is dyspareunia. So even just very right at the entrance, there's pain, or pain with deeper penetration, difficulty or pain or leakage with orgasm. Um, then there's kind of the umbrella term of pelvic pain, which could include people who have endometriosis. So they have adhesions, they have restrictions, they have their pelvic organs don't move because of those restrictions. I see patients post hysterectomy, both surgical, medical, and natural, or menopausal. I see patients who have had post gynecological cancer surgeries. I see people with abdominal surgeries. So I see patients with tummy tucks because that can really affect the bladder function as well. Um, You would also see patients who have coccyx or tailbone pain. So it could be a trauma from falling, or even a childhood fall on the coccyx, or even from a seatbelt injury from having coccyx pain. And then I see pregnant patients. So I see pregnant patients who have pelvic girdle joint pain, pubic symphysis pain, hip pain, lower back pain, muscle tightness, um, um, bladder leakage, or they also want a program to prepare them for childbirth. And so we can include that. Then, kind of the bread and butter is postpartum patients. So people who have had childbirth injuries from non-physiological childbirth, so that can include episiotomy, the use of forceps or a vacuum, or just often some women are induction, they have inductions, and they're kind of encouraged to push before they're really ready to push, so that all of those things can cause a lot of pelvic floor trauma. They also might come for diastasis recti, which is the separation of the rectus muscle. Prolapse, so pelvic organ prolapse can happen during pregnancy, and it can happen postpartum. And then I see also a lot of women in peri and menopause right now. So perimenopausal women are, coming to me with also some of the same complaints, but it's kind of being mediated by hormonal changes. So um, pain with penetration, the bladder leakage, not able to have the same kind of core strength they might have had before. Um, Strength programs. I mean, it's prolapse. It's really can go on and on with that. I also see men, not as many because men don't like to refer themselves quite as much. But I've seen men who have pelvic pain from lifting too heavy at the gym, or they do work that requires a lot of lifting and pressure, and actually that goes for women too, like, so women who are um, women who have jobs where they're maybe nurses or lifting people in healthcare situations, teachers, because teachers don't get to go to the bathroom, so they might have retention and bladder issues. It's pretty it's quite a long list. So that's why someone would come
That's
say,
what I was just gonna say. The list is so long.
So pretty much everyone could
yeah,
benefit. This is what I'm mad about because I found out after I started going, I found out that in France, part of their postpartum care includes pelvic floor physical therapy. Come on,
yeah.
America,
Well,
get with the program.
it's not only France. I mean, it's most of the Nordic countries. I'm pretty sure it's Australia. There might even be other places in, the Middle East, or India. Like, we are so behind. We are so
I'm
behind the
so mad.
times.
Me too.
And I mean, and it's scary because I think things are just going to get worse for women's health right now. So, and I think that we still, women are still being gaslighted about their experiences. So, I mean, when I started back in 2003 or 4, and I've had so many women tell me that they were having leakage. They might have had, a few pregnancies, and they would complain to their physician, and they literally were told, "What do you expect? You had children. You were pregnant." Or I have other patients who have pelvic pain, and they're still told, "Have a glass of wine, or go for a walk, or relax, or just go bear through the pain." So
It's so bad.
I'm sorry to say that it's still really bad, that it hasn't changed much. I mean, what has changed because menopause is having a moment finally. So now they're on social media. There are, you know, people can learn from there's some really great doctors, as Rachel Rubin and Kelly Casperson, people I've met at conferences in New York. And so they're on board with pelvic floor therapy, but they're also on board with just saying it like it is, and helping women find their voice to fight back. Because for a long time, my profession, we were in the trenches. I've been seeing perimenopause and menopausal women, for years. And to try to communicate with their physicians that maybe try some vaginal estrogen, or it was torture. So now there's a little more opening up, but it's still a very difficult road.
Okay, so then what does that look like? Somebody hears all of the symptoms that they might
Mhm.
have or a reason to come to you. So they come to your office.
Mhm.
And what does therapy look like? And can they do some at home? Because I know
Oh,
you said you
absolutely.
did some stuff on Zoom when we had the pandemic and nobody was seeing anyone in person. So what does that look like?
I will tell you, during the pandemic, I had never done virtual therapy before, and my phone was ringing off the hook.
I bet.
And it worked better than I thought it would.
Good.
So, and I'll show you some of the things that I use to. So when someone comes to see me, I send them a detailed intake form because I want to know what's going on, and have some background. And I mean, as I'm saying, I can have such a range of patients. So there's not one prototype. There's not one, everyone is individual, but I look at them as a whole person. And, I start with the subjective exam, and then I do a movement exam. So I look, with their clothes on. So I look at their spine, I look how they're moving, I do functional movements, I have them twist, I have them bend, I look at a squat, I put them on the table and I check their hip range of motion, I check their hip strength, I check their parts of their nervous system, what's called neural tension, to see if there's any nerve pain. I look at their abdominal wall. I check for diastasis. I check with them lying face down. I check all the different um, pelvic girdle joints. I check their spine. I check their rib cage. I see how they're breathing. And then I invite them for a pelvic floor exam. So, pelvic floor exam. So, I'm just going to grab my pelvis. Um, so you can see now. And and I explained that a pelvic floor exam is not like going to the gynecologist. It's a muscular skeletal exam. So so I'm looking at the muscles and the nerves and the ability of the muscles to contract, to relax. Are there trigger points? Are there tender points? How does it function? And I will also do an exam of what's referred to as the perineum. So, and this is very typical. It's called a Q-tip test. So you use a medical Q-tip and you check along the perineal body, along the labia, in the labia minora and majora. You're really looking to see, is there tenderness? Is there inflammation? What nerves are involved? Because there's several different nerves that innervate all different parts of the pelvic floor. And
Mhm.
then I have that objective information. Then I put on my gloves and we use lubrication and I explain, pop this off. So then I do, so they're lying on their back with their knees up, and I use one or two fingers, gloved fingers, and I come in and I check the integrity of so these are more of the superficial first layer muscles, as I just described about the perineum. And then I go and I check the deeper muscles. So the pelvic floor is 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 a sling and a bowl. And so just like any other floor, it's there to serve as support for whatever is on top. So I'm looking at the deep muscles and I'm asking them, I'm seeing, do I feel that they can contract? Do I feel that they can relax? Is there any pain, tenderness? Is there nerve pain there? And then I'll go to the other muscle. I'll do the same thing. And then I'll check the muscles that are up in the area behind the pubic bone, because this is where the urethra and the bladder live. So I want to check the integrity of those muscles. I'll check for a female, I'll check the integrity of the anterior or front vaginal wall. I'll actually check on the urethra and see how that feels, because it should feel firm and not mushy. And then I'm going to check. I'm going to check the muscles that are what we call the fast twitch muscles. So those are the muscles where I am these behind the urethra, because these are the muscles that have to quickly close the sphincters if there's a bladder issue. The muscles of the deeper part of the pelvic floor those are your endurance muscles. So I'm checking for a more like endurance or longer rest. And then um, that's pretty much the basis for the pelvic floor exam. Some patients I might do the exam rectally, because if they have so much pain and they're not able to tolerate any vaginal penetration, I can get very good results from doing a rectal exam, and you get to check the muscles that are deeper by the tailbone. But I can even get up to this deep obturator muscle there. So you really want to find you really want to find the driver for what's happening in the pelvic floor in order to have a plan of care.
Okay, I did not realize how thorough and how much
Hmm.
went in to the exam.
It's a lot. And sometimes you don't do it all at once.
Yeah, if okay, so you find something
Yeah.
that's tender or that, doesn't feel like it's up to par,
Right.
then, what does the therapy look like?
So what I left out is, for females, I can also see and check if there's a prolapse. So I want to know, is there a bladder
Mhm.
prolapse? Is there a rectal prolapse? I can also check, and I can actually go on, try to find the cervix and see if that's moving correctly. So um so if it was someone who who had pain with penetration, who had what we call non-relaxing, short, tight pelvic floor muscles, that's going to look very different than someone who has perhaps weakness with overly lengthened pelvic floor muscles. So for someone with very tight muscles, if we're able to do internal vaginal exam and they're able to tolerate that, then this is one of the tools that we would use for home, which is called a pelvic wand. So it's a medical grade silicone wand that because of the way it's designed, it has a smaller end and a bigger end. So someone can actually initiate their own therapy using the wand to do some stretching at the superficial layers, but also I teach them how to do the stretching and the mobilization of these tissues at the deeper levels. But it really helps if they're able to tolerate my manual work doing it, because that way they will be able to connect more with their breath. So and I really integrate it with mindfulness and diaphragmatic breathing. So um having an exam by a pelvic floor therapist can really help you understand what is exactly the problem. So once I know that, then I can prescribe this and teach them how to use it. And we might start with that. And it might take a while for them to even feel comfortable to do this, and I try to not put pressure on people, like keep it by your bedside table. Even if you do it for 2 or 3 minutes a day, that's a start. And then once they get comfortable with this, they learn to relax and really feel what's happening in their body, because I think that's often the disconnect. It's like, you have pain, it's hidden inside of you, you can't see it like you can see your
Yeah.
bicep. So some people think like, oh, is it just a hole that's tight? So once you really learn about your own body and what the model looks like, it becomes it becomes a conversation with your nervous system more than anything else. And so it allows the muscles to relax around the nerves, and that way to diminish the tightness and to get a more integrated feeling for what's going on. And what happens is, so then they might do that, and then all of a sudden they're emptying their bladder more efficiently, or maybe they're realizing, they don't have to stop and start having a bowel movement 4 times a day. They can just empty. So those are some of the things. And then we also might use vaginal dilators, which I'm going to show you. So this way, um, someone can practice penetration without the pressure of having a partner. And because I mean, most partners, they don't want to cause pain, they don't want to hurt you, but there's still this need for intimacy and for sex, and I think a lot of people feel pressured. So if you start with, I mean, this is a teeny weeny little vaginal dilator, and this is the same company, Intimate Rose. So these are all medical grade silicons. This would be for someone who really has a hard time having any penetration. They go up sequentially. Most people will graduate to something like this, but they come bigger. So this way, they have a home program where they can first use the wand, get that relaxation, because I think it's important to think of the pelvic floor three-dimensionally, which it is. So it's that bottom, it's the top, and it's the bowl. And then you can use your dilator to practice penetration and breathing, and use that to bring you closer to your goals with your
So
intimacy.
is tightness
So
one of
that
the most common issues you see?
it's a very big issue.
Okay.
Yes. And I will tell you that I see a lot of young women who have that. So they are, they're perimenopause. I'm talking about, young women in their 20s or, early 30s. They have a lot of tightness. They might have undiagnosed
Mhm.
endometriosis. So that's something that I will take a more of a history. Do they have very heavy periods, where the periods so bad that they had to miss school and or work, or were they never able to put a tampon in, because that's a big
Yeah.
clue. So that there's millions of young women who have those issues. Um, I was just gonna say, I also see. I mean, I have a young woman who um, had a hysterectomy. She's 31, and because she had cervical cancer. So
Wow.
after hysterectomy, your muscles can tighten up, and it's very painful, especially someone who can't take any type of hormone, including topical hormones. So that is a very large component, and it can happen after a C-section too.
Okay.
So, I assume you're a fan of
Y-
vaginal estrogen,
mhm,
and
very
how does that
much.
help? Because I think, well, you tell me, but I would
Okay.
imagine that some of these symptoms maybe present later on in life around peri and postmenopause, with bladder leakage and
Yep.
vaginal dryness and pain with intercourse and all of this.
Mhm.
So, I mean, does
Yes.
that get worse as we age?
Well, it can, because all of the tissues of this first layer, the vulvar, the vestibule, which is the deep layer right above the vaginal opening, these are all hormonally dependent.
Okay.
So as you start going through perimenopause and you start feeling some irritation there, there might be some, some redness or some irritation. The estrogen will help that because it will plump up the tissue and add collagen to that area. Um, it's referred to as the genitourinary symptoms of menopause. So that's a collection of symptoms that includes all of these things I described, which used to be described solely as vaginal atrophy. Now it has a broader
Terrible
I
umbrella
name.
know, the
term.
worst
Yeah,
name.
terrible name, horrible name. After, I mean, back in the 2010s, I had choked saying that word because we didn't have that.
Yeah.
um you know so estrogen supplies all of these tissues, but it also affects the urethra, so the urethra and the bladder. So as we go through perimenopause and start to have those changes, the stiffness of the urethra decreases, which is also an aging issue.
Mhm.
Because, I mean, here's a fun fact. So after around age 20, the strength of the urethral sphincters, those are the muscles, the internal and external urethral sphincters that close off the flow of urine, they decrease strength by 2% every year. So,
This is so sad.
so
So your
estrogen,
brain, this is like any other muscle. It starts
Yeah.
to lose strength or
yes,
okay.
yes.
So no
But
difference in the pelvis.
no, but and interesting enough, just this past year, a group, I think they're residents or interns of that work with Dr. Rachel Rubin in sexual medicine in Washington. They proposed, and now we're using the term, the genitourinary symptoms of lactation, because the same issues happen if you are breastfeeding and you're postpartum, because when you're breastfeeding, the hormone prolactin is in abundance to encourage milk production, and it's decreasing estrogen. So now you have so many of the patients that I see, they also need vaginal estrogen, and it's perfectly safe as if you're breastfeeding, but they are trying to recover as well all of these tissues, and with the same issues as perimenopause, trying to have sex, having painful sex, having some bladder leakage, having muscles that are weak. So it starts in a way, it starts in postpartum. And then if you don't get any treatment and then wait, say 10 or 15 years to start getting treatment, you can still get better, but it's kind of laid the groundwork for, maybe there is a little more prolapse. Maybe there is pelvic floor muscle true atrophy in the muscle. And that's something that a pelvic floor therapist can feel. Like one side just might feel really thin, the other side might have good bulk. It could be because of the way the baby was sitting and, towards the end of the pregnancy. It could be from just the pressure, but they're related, and they're very much, it's very much a continuum of the same issues that happen and that we treat for.
So bladder control can affect women that have had children or someone who hasn't had children just with age, like you were saying, with a 2% decrease, correct?
Yes, yes, but there's a high number of young elite athletes, female athletes, who leak.
And is that because of
So
movement?
that's because of tightness. So it might be, so if they
Interesting.
have, if they're they're strong, they're doing their sport, they might have so much tension in their pelvic floor that at certain points in their, maybe in their lift, or maybe in their, if they're volleyball players, in their whatever it's called, push, that's where they're leaking. So that's also a thing. And children, I mean, children it can also start in childhood, because children who are chronically constipated and don't want to go to the bathroom at school, they develop these bad habits, and then they have tight pelvic floors also. So it's really a continuum from childhood to adulthood, but it's all treatable. I mean, that's the good news.
Yeah.
There are options for treatment, but with exercise, that's a whole other thing. And I see that in my patients, and I see that in the general community of women who lift and exercise. And I think that's also really important to talk about, because there is treatment and that can change. But we need to be really specific about figuring out what it is that's causing that leakage. Because for one person, it could be, as soon as they do a lift. For someone else, it could be jumping on the trampoline. For someone else, it could be, even just taking a walk. So I think that's for perimenopause and menopausal women, this is a really good place to have a discussion, because there's 40% at least of women in this country leak, and
Yeah.
they leak with exercise.
Well,
And
okay, let's maybe look at, like, if somebody were to come in with prolapse.
Mhm.
Um, well, prolapse number 1, but then also just, like, I wanna know the limitations for somebody that, because I get this question all the time. I have prolapse, you know, "Do you think I can lift heavy?" And first of all, I'm like, "I'm not your physician, number 1."
Oh.
Wrong person to ask, and I'm always going to say, "Ask your physician." But for, like, what are the limitations for someone with prolapse specifically? What does that look like? Would you say don't lift heavy? There's a
Yeah,
lot of mixed conversations here in the
yeah.
space.
Well, I think first of all, it depends on their symptoms and when they feel the prolapse. So if they only feel the prolapse, if they only feel that vaginal pressure and prolapse when they're doing, you know, lift X at so many reps in this range, then bring it down. So let's try to train the pelvic floor with that, in that exercise, because maybe it's their breathing pattern, maybe they just are not coordinating their pelvic floor with their, the stiffness in the abdominal wall, maybe they're have too much of a forward posture when they're lifting. So it really there's a lot of nuance that we can break down. And I would never tell anyone just stop lifting. So I think that's really important. I also think that there are things women can use for prolapse to try to see, sometimes a pessary is a good option. So a pessary is a hard plastic object that you would get from a urogynecologist, or now in our country, some pelvic PTs are being trained in pessary insertion, which is fantastic. But because it might be that just getting that bladder or bladder neck up a little bit higher in the pelvis allows the muscles to contract more robustly, and then it eliminates that feeling of something coming out of the vagina. So we really need to look specifically at each person, but there's no hard no in having prolapse. But you wouldn't want to keep going on that same path where you're doing
Mhm.
that lift, where you're, every time you're reinforcing that you're feeling that pressure, because that you're going to be, you're not going to feel good, and you're going to limit ultimately, the pressure dynamic in your trunk. And so there are solutions. There's definitely solutions. It's very specific, but that's what I
Also,
would
I mean,
say.
the breathing comes into play too, because I've had people that when I talk about bracing for lifting to protect the spine, they almost
Hmm.
bear down where then they
Yeah,
pee because they're pushing pressure down when,
right.
you shouldn't be pushing pressure down.
Exactly. Well, that's why, I mean, one of the things that I think can really help with lifting, and if someone has a weak pelvic floor or has prolapse, is to use these vaginal weights, because this is something. Ooh, these are different weights that come in 6 sizes, and I think that it can give someone the feedback to that they're actually lifting and pulling in their pelvic floor as they're recruiting their abdominals and then going into the lift. So it's again, it's if you're not aware of what you're feeling and what the feedback is, it's really hard to get better. But you can have these options for improving with weights, with coaching. There's no reason now to not have those options in order to continue your fitness journey.
Okay, I love the weights. I ordered them. They still haven't come to
Oh,
my house. It's been like a
oh,
month.
really? Oh,
Now I'm gonna
really?
go back and look. Maybe you know how sometimes you think you press
Sad. Yeah.
purchase and then it doesn't actually purchase? So I gotta go
Yeah,
back and look at that. But the
yeah.
vaginal weights, um, they come in obviously different weights. They look like little mice to
Yeah.
me. I don't know why.
Don't
Same.
they? No, they totally do. Yeah, so the white is the lightest, then it goes to pale pink, a little darker pink, more like a
Okay.
fuchsia. And then I always, when I show patients, I would, this one is if you're like a serious cross trainer or
Yeah.
Olympic
Mm.
lifter,
Okay.
because this one's pretty heavy. But
Yeah.
I think it's a great tool, and it doesn't mean that doing Kegels alone is the answer to the problem. But
Yeah.
you have to use the pelvic floor to understand what it is and to integrate it into the exercise and the activity and the breathing, because one of the main tenets of breathing awareness and diaphragmatic breathing is understanding that every time we breathe, we take a breath in, our breathing diaphragm, which is 360 degrees around, and the pelvic floor are always moving in the same direction. So you take a breath in, the pelvic floor and the diaphragm push down and create that pressure, and then when you breathe out, and if you brace your abdominals, everything comes back to its resting position, or you get a contraction. So, learning how the breathing is with the pelvic floor integration, I think, is critical for anyone who wants to lift heavy or just lift or do, high intensity exercise. It's really an important part of that rehab
So
journey.
a lot of this therapy is probably creating awareness, body awareness even, because I'm sure
Exactly.
if you tell someone, "Okay, tighten this part of your pelvic floor,"
Yeah.
they I don't even know if I would know specifically how to do certain exercises. So is that part of the beginning of the therapy is breathing or like contracting certain
Yes.
aspects of your body?
Yeah, it's exactly because there are, I over the years, I've had many patients who I might be doing the exam and asking them to contract, and there's different specific cues I might use. So I might say contract like you're stopping pee, and or contract like you're stopping gas, because then you were accessing the deeper levator ani muscles. But some patients do something the opposite,
Mm.
so they might bear down when they think they're contracting, and then they're contracting when they think they're bearing down. um, and that technically is called dysenergia. It's like a complete mix up of what you actually want to do. So getting someone to be able to feel that and understand that, and to be able to do it without engaging their glutes or pulling their adductors together, or sometimes they do this, is like it's a tremendous shift in their awareness. And to me, that's foundational. Like that's the
Mhm.
foundation of how you heal pelvic floor dysfunction. It has to start with this inner awareness. And I think, it's the hands-on therapy, it's the breathing, it's using these tools that help give someone, their toolbox to be able to go on with this. So yeah, 100% the breathing. And I always ask people, are you doing any kind of mindfulness program? Are you taking any time to like just use an app? Like I'm a big fan of Headspace,
Mhm.
the Headspace app, because you can open the app and they have a 1 minute breathing exercise with a visualization. Like even if you just do that, that's a lot. Like now you've calmed your nervous system, you've relaxed your pelvic floor, you've had that integration of the central and peripheral nervous system. Like that's priceless and that's foundational for all this work. So, it's kind of the same way I approach once I get someone to do more exercise, like I give them some foundational strengthening if they need it. So maybe just, you know, um, um, clamshells or bridging or something to just feel the muscles and then progress to more to standing, to different positions, to weights. Like you have to have the foundation, I think, in order to go further.
So, if somebody were to come to you, I know this could be a huge range, but how many visits on average would somebody come? Is it like 25? Is it 10? Is it what does that look like?
Um, People do ask that, and it's a hard question. But I mean, I can give them certain guidelines. So because I don't when they ask that before I've met them and evaluated them,
Yeah,
like I don't
I
know.
don't
Right.
know.
I don't even know you. Like so that I have to, I tell them, let's have the exam, because after the exam, we sit down, I talk about what the findings are, what I think, in my best professional opinion, is the best plan of care. And then we go from there. And, I know people have expectations and financial considerations too. So I want it to be, I want it to be work best for you, but you also have to commit to doing the homework that I'm telling you to do.
Yeah.
So, because you'll get the best results if we really collaborate together on this. So, we know that basically with muscle strengthening, it takes 8 to 12 weeks for muscle to change. So, if someone was really working on prolapse and strength, I would say it's probably going to be 8 to 12 visits. If someone comes to me with pain, pelvic pain that they've had for 5 years, I'm gonna, I might say it's gonna take a minimum of 12 visits, and then we'll reevaluate and see from there.
What about bladder
There,
control?
Bladder control, so with stress incontinence, we actually have the evidence-based studies on pelvic floor physical therapy for stress incontinence. So a typical program could be 12 weeks, but that doesn't mean that they're coming to see me for 12 weeks. They might come for 6 visits and then they might do the rest at home, and then they might come back and check in.
Mhm.
So, because we have very good stats on that. We know that, and this is over many years in several countries, that at least around 50% of women who do pelvic floor therapy for stress incontinence have 100% recovery,
Oh,
which is really
that's
good.
great news.
Yeah. 75% might have most issues, improved or full recovery. So there's still some that it might not work for. And if it doesn't work, then we have to look at, maybe you have a bladder and bladder neck that are sitting too low. Maybe you have intrinsic sphincter weakness, and maybe like we can still do the therapy, but maybe going to the urologist and having um, collagen injections might help to, it really depends. Because if they have those other issues where the bladder is sitting too low in the pelvis, they're just not going to get that closure from the back wall of the pelvic floor where so you create a back stop and a front stop. And um, so we might need to look at other things, but I think overall, those are pretty good statistics.
Mm.
So, I have some patients who come to me during the later part of their pregnancy, and it might be because they have those pelvic joint pain. They might have some, and I'm able to do some internal pelvic work with pregnant patients as long as their doctors sign off on it and they don't have any type of placental issues. Um, and then at 34 weeks, we can start doing perineal massage. And again, for that, there's good evidence-based studies that decreases the incidence of third and fourth degree perineal tears, which can lead to fecal and urinary incontinence and chronic pain. So we have studies on things, and so I'll always try to impart as much information as I know, but sometimes it's like, let's try this, let's see how you are let's see if in a couple weeks you start to feel improvement. But I do feel, when for the most part, I will always tell someone you can be much better, because they probably can. I know they
Yeah.
can, and they will because they're already starting something.
Mhm.
So I try not to set expectations like you're going to be better in 6 visits, because probably you're not, because most people take 7 to 10 years to come for treatment, or
Yeah.
they've seen 7 to 10 doctors who didn't give them the right
Right.
information. So it's really a different journey for different people, but um, it can be really transformative for people.
I bet.
It can really be, when someone tells me that the work has changed their life, like, I don't want to ever retire, because that's like
Very
amazing.
rewarding.
Very
Okay,
rewarding. Exactly.
before we go, I want to know, do you have a tip that you can give our listeners of an exercise that just strengthens the pelvic floor? Like whether they're driving in their car or they're sitting or they're whatever. Is there a easy tip or exercise that people can do that just strengthens the pelvic floor overall?
You know, I would say s- sitting is a great place to start because it's functional and we all have to sit. So, sitting in the car or first on a flat chair, and I'm going to just use finding a neutral pelvic position, meaning the same as if you were standing up straight and you were not arching or slouching, but just a relaxed neutral position, because that way you have the whole sling part of the pelvic floor in contact with the seat. And first breathe and see if you can feel that when you breathe in, you can sense that there's some sense of dropping or relaxing the pelvic floor. And then once you do that, exhale and see, if you can contract, give yourself the cue, stop the gas, see if you feel the anal sphincter tightening and pulling up. And if you can feel that, then you already are winning because you have some awareness of that. If you're having leakage, do the same thing, but give yourself the cue, stop the flow of urine, because then you're going to work more on the area where those sphincters are. You're still going to get those deep muscles, but if there's a sphincter deficiency, you're going to start to get that as well. So start with something really basic, see if you feel it, and keep practicing that. And then, not everyone needs to strengthen, because we talked about people with the high tone, non relaxing. But if you can feel that you can relax and contract, then you know that you have some good mobility there. And good mobility is like the best place to start.
Oh, fascinating.
Yeah, thank you so
Thank
much,
you so
Deb.
much. Deborah, for joining us. This is such a great conversation and so needed.
Oh,
So
I'm so
needed.
glad. It's my
So,
pleasure.
how do people can you work with people via Zoom? So how do people find you?
You know, well, they can find me on my website, Four Corners Physical Therapy. They can also find me on my Google profile. I actually have a lot of more information. So if you just Google Four Corners Physical Therapy in Montclair, New Jersey, you'll come to my Google profile. Um, I'm I have a Facebook business page, so Four Corners Physical Therapy. I'm on LinkedIn. I have a Instagram. It's at Four Corners PT, but it's not great, and I have to work on that. I tend to put more other things, um, and those are the best ways to get in touch with me. My email, Deborah at fourcornersphysicaltherapy.com, and it's all spelled out, FOUR, Corners Physical Therapy.
Right.
So yeah, I'm excited. I'm so excited to share the information because as much as as much as I think and my colleagues and people who are already doing it think that everyone knows, we don't know. We
Mhm.
don't know.
Yeah.
So um and we could talk so much more about more specific things. But this was great. And I think that um I'm very grateful that you gave me this opportunity. I feel like I'm sitting on the shoulders of some really amazing people that you two have interviewed. So,
This is
Yeah.
fantastic. We're so grateful for your knowledge, your education, and
uh,
time to share this.
thank
As I
you.
said, it's a very important subject. So thank you so much, Deborah.
Oh, my pleasure. Anytime.
Thanks for listening. If you enjoyed this episode, please consider giving us a 5-star review and sharing the Body Pod with your friends. Until next time.